Order. Welcome to meeting number 67 of the House of Commons Standing Committee on Health. Today we continue our study of oversight of medical devices, breast implant registry, with a 2-hour panel including researchers and professional organizations. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. A few brief comments for the benefit of witnesses. You have, for those participating remotely, you have on the bottom of your screen the choice of floor, English, or French. For those in the room, you have an earpiece and you can select the desired channel on the microphone set in front of you. For those participating remotely, please refrain from taking screenshots or photos of your screen. Today's proceedings will be made available on the House of Commons website. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. I'd now like to welcome the witnesses who have joined us by video conference today. Dr. Jan Willem Cohen-Terfert, Professor of Medicine at the University of Alberta. I hope that was a reasonable attempt at the pronunciation of your name, Doctor. Dr. Stephen Morris, President of the Canadian Society of Plastic Surgeons, and Dr. Lorraine Greaves, Chair of the Scientific Advisory Committee on Health Products for Women. Thank you all for taking the time to appear today. We're going to start with Dr. Cohen-Terfert. You have 5 minutes for an opening statement. Welcome to the committee. The floor is yours.
Okay, thank you, Mr. Chairman. So my name is Jan Willem Cohen-Terfert. I'm a professor of medicine at the University of Alberta, but also emeritus professor in medicine and immunology of Maastricht University in the Netherlands. And currently I'm also a member of the expert panel of medical devices of the European Community. So I did my training and education in the Netherlands, but after finishing my MD and PhD, I was invited to work at Harvard University in Boston in the United States. And in 1993, I returned to the Netherlands with a fellowship of the Netherlands Academy of Science. And at that time, I started my clinics for patients with autoimmune complaints associated with breast implants. And based on this experience, I'm pleased to share with members of the Standing Committee on Health some background information on the safety or unsafety of breast implants. First of all, there have been several scandals with breast implants. Breast implant products are not always in compliance with international norms and standards. And as an example, there were 3 scandals. One in 2010 with Polyimplant Prosthèse, PIP from France, and in 2015 with Silimelt, a company from Brazil, and in 2021 Belagel from Korea. Furthermore, the Dutch National Institute for Public Health and Environment published in 2015 a market surveillance study that demonstrated that the technical findings of all 10 manufacturers that are having a market in the Netherlands with breast implants were not in order. And in one case, there was even a very high level of contaminants in the breast implant. Finally, in 2018, as well known, the International Consortium of Investigative Journalists released the implant files demonstrating many shortcomings in breast implant clinical trials. So what are current diseases that are associated with breast implants? There are 3 different types. Firstly, a malignant disease. In 1997, a specific implant-associated malignant disease was firstly reported, so-called anaplastic large cell lymphoma, BIA-ALCL. Based on the Dutch mandatory registry for pathology specimens, Daphne de Jong et al. Demonstrated in 2008 already clearly that BIA-ALCL in the Netherlands was caused by the breast implants. In 2011, the FDA issued a warning, but stated that they were not possible to identify a possible association between breast implants and BIA-ALCL. But since most patients with ALCL had textured implants, the FDA and Health Canada requested Allergan in 2019 to recall its textured implants. More recently, in 2023, the FDA and Health Canada issued a safety communication that also other lymphomas and breast implant-associated squamous cell carcinoma may occur in patients with breast implants. Although an accurate estimation how often these malignant tumors occur in patients with SBI do not exist, ALCL researchers calculate the risk to be 1 in 2,832 women. Apart from malignancies, there's also various autoimmune diseases that are reported to occur more frequently in patients with breast implants. Also here, the estimated risk is very difficult to quantify, and it was for a long time debated even if breast implants really were a risk factor for the development of these autoimmune diseases. In 2018, however, a very large study from Israel convincingly demonstrated that autoimmune disease occur more often in patients with breast implants than in women without these implants. Patients with breast implants appear to have a 45% higher risk to develop autoimmune diseases such as sarcoid, systemic sclerosis, multiple sclerosis, rheumatoid arthritis, and other autoimmune diseases. Just as found for malignancies, most diseases occur only after 10 years after the implantation. And finally, there's a third group of diseases. Patients with breast implants often have symptoms suggestive of an abnormal functioning autonomous nervous system. Symptoms that these women have include severe fatigue, widespread pain in muscles and joints, severe dry eyes, severe dry mouth, feverish feelings, and cognitive impairment. Nowadays, this disease is called breast implant illness or autoinflammatory immune syndrome induced by adjuvants due to silicone incompatibility. The symptoms also here occur generally after 7 to 10 years after the breast placements. And explantation causes in about 80% an amelioration or disappearance of the symptoms. Although here also an accurate estimation how often this occurs does not exist, our studies suggest that 1 in 4 women, so 25%, may develop at least 3 symptoms suggestive of this disease 10 years after breast implant. So why do we need a national breast implant registry? It is estimated that about 3 to 4% of women in Western countries have breast implants. 70% are placed because of cosmetic reasons, whereas 30% are placed because of a reconstruction after mastectomy. When the PIP implants were recalled in the Netherlands, there was only a voluntary registration, a so-called opt-in registration. And this meant that only 10 to 20% of the women with PIP implants could be traced. So furthermore, with a registry, there is a possibility to calculate how often local and systemic complications really occur after breast placement. Since there were never randomized controlled clinical trials performed to demonstrate the possible safety or unsafety of breast implants before it was registered, we currently only have post-marketing surveillance to monitor its safety. Manufacturers need to conduct these studies, and plastic surgeons need to report events to the manufacturers. Unfortunately, there are no criteria for these reports. Reports are only infrequently made by surgeons, and reports are not peer-reviewed, and these reports are not open to the public. Because there are several signals that breast implants may not always be safe, it is prudent to start with a registry as soon as possible. And as discussed, this should not be a voluntary opt-in registry, but a mandatory opt-out registry, where only the patient and not the surgeon has the choice to participate or not. What are the requirements for a registry? As mentioned above, opt-out.
Dr. Tefert, we're well past time. If you could,
Yes,
you could conclude, you'll get lots of chance to elaborate during question and answer.
Okay. So there's a few things. An opt-out system. The data set that can be used could be the same as in Australia and the Netherlands, but there should also be a PROMS data set, so patient-reported outcome measurements. Compliance with the mandatory registry could be an issue. In the Netherlands, it's arranged that all hospitals and all private clinics have legal responsibility for the registration. And in addition, compliance to the registry is a requirement for renewing licenses of plastic surgeons. To facilitate the registry, manufacturers should be asked to develop barcodes on the implant so that with barcode scanning module, the registry can be done without mistakes. And the funding of a registry might be an issue. In the Netherlands, it's established that patients pay 40 Canadian dollars extra for their surgery. Patients with breast reconstruction do get this reimbursed by their health insurance. So in conclusion, breast implants are high-risk medical devices. Long-term sound epidemiological data are, despite the fact that these breast implants are now more than 60 years on the market, not available. Recalls have been made in the past and are probably needed in the future. Recalls are not successful if there is no good registry. And it is my opinion that there's an urgent need to start a national breast registry. The registry should be used by all surgeons that place implants, and the registry will provide us with better information about the diseases that are associated and or caused by these breast implants. Thank you very much, Mr. Chairman.
Thank you, Doctor. And next, we're going to hear from the President of the Canadian Society of Plastic Surgeons, Dr. Stephen Morris. Dr. Morris, you have the floor.
Great, thank you. I'd like to thank the committee for the opportunity to appear here today and provide some information regarding breast implants. I agree with my colleague that the regulation of surgical implants is key to patient safety. I'm Steve Morris, as you heard. I'm a plastic and reconstructive surgeon. I've been working in Halifax for 30 years. I have a research lab, and I've been doing laboratory research for the last 25 or so years. Currently, I'm president of the Canadian Society of Plastic Surgery. I started my residency in the 1980s, and at the time, breast implants were flawed, results were poor and unpredictable. Gradually, the implant manufacturers improved the devices and results improved. Due to the concerns about safety, in 1992, there was a moratorium placed on silicone gel implants. So in order to do any kind of reconstruction, we had to use saline-filled implants for a period of time. The problem with the saline-filled implants is that there's a 1% failure rate per implant per year. So spontaneous rupture is a consistent issue. Gradually, silicone implants were allowed back on the market, and Health Canada basically put the onus on the implant manufacturers to collect data. Just to back up, what do we use breast implants for? Well, I do a lot of breast reconstructive surgery using implants. Congenital causes for breast deformities such as hypoplasia or asymmetry or other more unusual breast deformities. Transgender patients require breast implants, and then finally there's cosmetic breast augmentation. The numbers of these procedures varies from surgeon to surgeon in different practices. There's always been some level of concern about breast implant safety. In the 1980s style implant, there was an unacceptably high rate of implant rupture because as the manufacturers tried to achieve a better implant, they made the capsule thinner and thinner and the silicone more viscous, and this ended up causing a lot of ruptures. Silicone has been of concern because of what it could do in the body, but generally silicone was first selected because it's relatively biologically inert. But there always is a capsule around any implanted device. Whatever type of implant in the body, there's always a capsule around, and that seems to cause a lot of the problems in a certain subset of the patients. When the moratorium was announced in 1992, there were hundreds of research projects looking at the safety, particularly looking at autoimmune. And at that time, there was no convincing evidence, and that's why Health Canada allowed the implants back on the market with the understanding that the implant manufacturers were going to study the data. And that's why we're here today. It's said that the best time to plant a tree is 30 years ago, and the second best time to plant the tree is today. It's the same with this registry. Today is the best time to start moving forward with this issue. We would have excellent data by now. The ALCL, breast implant associated ALCL, which is a large, very serious tumor caused by breast implants, textured Allergan implants were associated with it in the highest numbers. But there's no doubt that there's a relationship between anaplastic large cell lymphoma, which is a form of non-Hodgkin's lymphoma, and the implants, and that's the reason they were taken off the market in 2019. If we would have had that data when we first got an inkling of ALCL, we could have alerted all those patients, all those surgeons, and explanted those implants and stopped the production of it, setting back the clock about 10 years. So we lost that opportunity, or more. Unfortunately, right now, there's no good way to track the number of patients who have received these types of implants. A registry would have accomplished this easily. In every surgical procedure, the surgeon is required to disclose to the patient the cost-benefit analysis of the operation. What are the risks? What's the financial cost? What's the pain and suffering associated? And then the goal of the operation. And if we do not have adequate data on breast implants, we can't correctly advise our patients. As surgeons, we want to achieve good results, excellent results every day, but we want to do it safely. In this patient population, believe it or not, after what you just heard, we get great results very consistently. I've been practicing for 30 years. If I would have had terrible results and patients that were badly effective, I would have stopped doing these types of surgeries a long time ago. But clearly, we're getting great results most of the time. But then there's cases that we don't know about, we've lost them to follow-up or what have you. So I think in order to provide optimal and safe patient care, we need to create a national breast implant registry. And I had a quote from one of the papers I read in preparation for this, that the obligation for patient safety lies not with the doctor who uses the medical device, but with the government which regulates the medical device.
Thank you, Dr. Morris. And finally, Dr. Lorraine Greaves, the Chair of the Scientific Advisory Committee on Health Products for Women, appearing virtually. Welcome to the committee, Dr. Greaves. You have the floor.
Thank you very much. In addition to chairing the Scientific Advisory Committee on Health Products for Women, I'm also a senior investigator at the Center of Excellence for Women's Health based in Vancouver and a clinical professor at UBC in the Faculty of Medicine. I'm a medical sociologist, so I'm trained to analyze the links between health and various systems. There is no doubt that a breast implant registry would benefit Canadians and that all measures should be taken to establish one. However, such a registry is just one example of the need for a comprehensive system for tracking and monitoring medical devices in Canada, and I want to briefly address both aspects. Women's health has a long history of neglect, and that's included exclusion from clinical trials, under-researching of key health issues specific to women, and under-researching of women's presentation of shared health issues, such as cardiovascular disease, just being one example. This is a result of a long-term systemic bias in health research and in treatment. Remedial actions have been taken by the Government of Canada around this neglect, one of which has been the funding of the Centres of Excellence program between 1996 and 2012. There were 5 centres and a working group on health protection. The latter group, including the centre I established in Vancouver, did do 2 reports of relevance to the issue of breast implants, and they are linked in the written remarks I sent to the clerk. A joint research program is the second initiative to remediate this problem that Health Canada and the CIHR launched between 2019 and 2020 to address key policy issues. It was called the SGBA Plus, that's Sex and Gender-Based Analysis Plus Health Policy Research Partnership. 2 of the 7 projects under that particular program are of relevance to today. One done by Anna Gagliardi at the Women's College Hospital, and her team analyzed the management of medical devices in Canada from an SGBA plus perspective, and she recommended a complete revision of documentation and procedures, and certainly SGBA plus training for industry. I led a team doing a parallel piece of work on SGBA on the management of prescribed drugs, and had similar recommendations, including the mandatory inclusion of sex-related data and gender-related data, the former beginning in 2023 on submissions for drugs and devices. So these both I think, speak to some of the oversights that we have in our current system. The establishment of the Scientific Advisory Committee is the third example, and we're mandated to advise on better management of drugs and devices that affect women. We've identified numerous issues with respect to both, and we've made those recommendations in concert with various planning efforts from Health Canada. With respect to the registry, as you've heard so far, the issue of the registry is extraordinarily important to those women who have had one implanted, in particular to those women who have had problems. You've heard about the problems. At the committee level, we have heard testimony from some of the women who have had problems, which is utterly moving and often relays catastrophic life-changing issues. The registry is of keen importance to clinicians and researchers as well, as it will provide more robust data. The request for a breast implant registry in Canada date back over 33 years. 33 years. As the last speaker said, that would have been the time to establish this. These include reports, special advisory committees, expert committees, at least 2 legislative bills, testimony, and recommendations from consumer advocates. Most recently, we had a Best Brains Exchange in March of this year, and now you are embarked on this study. I submitted a PowerPoint from the Breast Brains Exchange to you for background. You will see the timeline there. However, we still don't have a registry, even though many other countries do, and it's well past time to establish one. Discussions about logistics and pros and cons and arguments about objectives and complexity prevail, but 33 years is a long time to work out a system. It's ample time. It should include registration of all implants sold in Canada, implanted, replaced, explanted in both private and public healthcare facilities, including recall information. The members of the SAC, the Scientific Committee, are an esteemed and experienced group of clinicians, scientists, consumer advocates, and researchers. We have recommended action, and we were engaged in the Best Brains Exchange. A registry would finally provide a denominator for calculating risk. We don't have that at the moment. Therefore, we can't calculate risk, which underpins informed consent. And that affects clinicians. It also affects women. And we don't know the total number of devices implanted or explanted, replaced, failed, or succeeded. So we can't do this. And this lack of evidence, I would suggest, supersedes even the most strongest consent forms. It should also provide data for research to understand the dynamics of breast implant usage, something that gets very little discussion. CIHR should be encouraged to utilize the registry data, should we get one, to produce research for the public domain. And if implants and when implants take place in private clinics, follow-up healthcare utilization is in the public domain. So this is an issue for all Canadians. We've also recommended improved communication with potential recipients of implants and clinicians, including robust information about consumer experience and reasons and motivations for seeking impacts and alternatives to implants, lifespan, and relevant qualitative research. Even non-problematic implants expire and require replacement. Women need to anticipate this and learn about alternatives to breast implants. We don't generally do that at the moment, but at root, by and large.
Dr. Greaves, can I get you to wrap up? We're past time, and
Yep.
We've got a bunch of MPs that are really anxious to ask questions.
Okay, I will. By and large, this is a non-medically necessary procedure. Post-market vigilance, I'll just wrap up by saying a few words about this on all devices. Vanessa's law came into effect in 2019, mandating hospitals to report adverse reactions. There have been promises to extend this to long-term care and private clinics. We need that. And we need that to support a robust registry. And second, Canada does not yet have mandatory sex and gender related reporting of data in submissions by industry for devices or drugs, despite a federal SGBA plus policy. And therefore, we don't have adequate warning labels and consumer and clinician monographs. Promises have been made to improve this, and some promises have been fulfilled, but there's a long way to go. It is extremely important that if the pace of these commitments has been slower than we thought, that these goals should not be eliminated or reduced via departmental budget cuts. I will conclude by saying it's past time to have a registry, and it's past time to compel parties to take these important steps on medical devices. Thank you very much.
Thank you, Dr. Greaves. We'll now begin with rounds of questions, starting with the Conservatives. Dr. Kitchen for 6 minutes, please.
Thank you, Mr. Chair, and I appreciate it. And thank you to all the witnesses. I really appreciate your expertise and your dedication to the area, so I do appreciate that. As our chair indicated, we're eager to ask questions. We've got so many, I just don't know where to start. So, but I will start on the aspect, and I'll start with Dr. Tervert, and I apologize if I mispronounce your name. And you sort of talked a little bit about RCTs and randomized controlled trials. And that we don't have any along those lines. And because we're looking at this from a registry point of view, I'm wondering how you see collecting the data, assuming we're collecting that data, would be of value to produce those RCT research.
Okay, so of course, first of all, it's a recall registry, but you can implement prompts, so that's patient-reported outcome measurements, to the questionnaires that the patient have. So, if, for instance, in the Netherlands, they are currently doing that. They are registering all kinds of complaints in patients to see how often these breast implant illness occur, how often autoimmune diseases occur, and how often ALCL occurs. So those are things that can be implemented in the registry. It needs extra effort and a lot of work, but it can be done and it should be done.
Thank you. And so last week we had Dr. Nicolaitis here speaking to us, and basically what I took from part of his conversation was that there are no studies that are basically being done by the industry and by the companies. The studies that actually are being done by practitioners who are utilizing those devices. And so the question I guess I would have is the concerns about the research actually being biased in any nature because of that sort of background. Any comments on that?
Yeah, so many publications on breast implants are heavily sponsored by the industry, and I must confess that myself I was offered also to have a grant from the industry, but I had to sign an agreement that I never could publish anything without their consent. So I refused that. So that's not ethical. And it's not done by the industry of medicine, but medical devices seem to be more harsh in these kind of subjects than others. So there's very few well-granted studies performed because it's difficult to get a grant for such studies. You have to go to CHIR, which is difficult for such a, not well-developed field.
Thank you. What I hear around the room, and basically from the three of you, is that there's obviously an interest in creating this registry, and I'm just saying, putting that out there. Ultimately, I hear that there's value to that, and I know that Dr. Greaves, you had presented a PowerPoint presentation, and in it talked about things that you had looked at that would be required in a successful breast registry, such as, and I'll just read them quickly: clear objectives, stable long-term funding, independent financing, technically but responsive to stakeholders, simple interface, data upload, opting out concise data requirements, clean data which can be utilized and reported easily. And I'm just basically putting that up from one of the slides. I want to focus on the opt-out aspect of things. And we've heard from many of you on whether we should be opting out, should be opting in, and the concerns that we have about, number one, informed consent to the patient, and number two, privacy issues. And I think I'll start with Dr. Morris, if you would like to sort of speak to that, please.
Excellent question, Mr. Chair, and clearly the data is extremely clear about it. Opt-in has about a 20% uptake with patients. Opt-out has about an 80 or 90% success in getting the data. So if you're going to do the study, I wouldn't actually even suggest doing the study if it's an opt-in because they've failed. One of the advantages of us waiting 30 years to get this started is that we have lots of published data out there from other countries that have done all the trial and error. So there's some excellent studies on the other registries around the world that we can learn from. Germany and Italy have taken the approach of making the registry mandatory. So it's not even opt-out, it's mandatory to the surgeon and to the patients, which is, it's something to discuss. I think patient confidentiality is always important in any database of patient-related data. And in this case of having a national registry, it would be paramount to the success of the registry. Because obviously clinical data, and particularly with this type of subject, which is very sensitive and a lot of people don't really want to have that data out there, you'd have to mandate very rigid patient confidentiality parameters in addition to making it opt-out.
Thank you. And
Thank you.
Dr. Graves, if you want to...
Kitchen, you're out of time.
Sorry, I see I had so much time. Not enough time. Thank you very much.
Over to Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being here. And I also want to wish everyone a happy National Nursing Week. And my question is to Dr. Morris. You're talking about Italy, Germany, and we have heard about opt-out option in Netherlands, where all plastic surgeons are required to register the implants in the system except when the patient refuses to be included on the registry. Do you think this is the model that should be implemented, or what is your thought on that Netherlands model?
So first of all, disclosure, I am not an expert in registries, but I think there's lots of published literature on them. And I think what I would advocate for is developing a steering committee that makes those tough choices about registries, because I heard the ideals about the registries and those seem to make a lot of sense, and that's what's published. I think the Netherlands is one of the big four in the world. So UK, Netherlands, Australia, and US are the four models of registries. And I think the first thing that we should do if we go this route is to make ours better. So draw on the experience of other registries and make it even better. And one of the things that is important to the registry is to get the uptake of the surgeons entering the data, because they have to do all the data entry. So if you have it on a smartphone, have an app, you mandate it, as my colleague said, make their registration or something. You have to have a stick to make everybody comply. But I think it's very important to come up with a very definite plan.
And as a follow-up, how would people who opt out find out about recalls? We have heard that women are just now finding out that their implants were recalled in 2018 or 2019, and they have no idea they got recalled. So what is your thoughts on that?
Yeah, it's not a good situation, because in the breast augmentation population, it's often young women who are quite mobile, might have their surgery done in one city, move to a different city for a job or for family or what have you. And even though they might have best intentions at follow-up, and the surgeon may offer them follow-up, they, for one reason or other, they have no follow-up. Medical records only are like tax returns. You have about a 7-year window that you're supposed to maintain medical records, whereas I think in an implant, possibly it's a forever rule, because as Dr. Turvert said, a lot of these conditions related to the implant seem to be latent effects, that they might be 10, 20, or 30 years later.
Questions to Dr. Turvert. Dr. Turvert, is there any specific techniques or approach that healthcare professional can use to address the challenge of the mammogram who has breast implants?
I'm sorry.
So they can get the abnormalities if they have the breast implants population when they go for the mammograms. I know there's challenges are there.
Yeah, there's challenges with breast implants and mammograms. Breast implants, especially the older breast implants, are leaking, and if you got the pressure of a mammogram, it can cause more leakage and even rupture of the breast implant. So FDA warns against this. I personally also warn my patients, and ultrasound seems to be the best screening method for breast implants, and MRI is another option, but an expensive option. So, but ultrasound should be a very good alternative, and it's not yet in Canada the rule to have that.
And Dr. Morris, you want to add on that?
I just would add that clinically, the radiologists say there's really no problem. What they do is they do additional views to look around the implant at the breast, so the radiologists are quite comfortable doing mammography on implants.
Yes, but I see it from the other way. So many patients tell me that their problems actually started after the mammogram. So I'm not sure that radiologists see that.
And I want to ask that question to both of you. How would a breast implant registry help with monitoring the tracking cases of BIA or ALCL? You talked about that.
Well, for ALCL, it's clear that if you combine pathology data with the breast implant registry, it would be easy to see exactly which breast implant was used. So, for instance, it's been considered that it's mostly a macro-textured issue, because an allergen was blamed for that. But the Korea scandal in 2021 was actually that microtextured implants also can cause ALCL, and that was the implant that was specifically made in Korea. But there also the manufacturer was causing fraud and did not have a really microtextured envelope as they originally from the technical files should have done. So it's important for that to go back and to see which exactly implant caused the ALCL.
You want to add on that, Dr. Morris?
Thank you. All I would add is that if you have a registry of 1 million patients and say 100,000 had a certain type of implant that was associated with an issue, then almost immediately you could contact that 100,000 patients with whatever number of surgeons and highlight that this is a risk and offer early surveillance, much like breast cancer and lung cancer. Early diagnosis and treatment is going to improve the results of the treatment for the cancer that results. And obviously, then if there's a cluster of cases, you can take that implant off the market.
Thank you, Dr. Morris. Suite, Mr. Thériault, pour 6 minutes.
Mr. Thériault, you have 6 minutes. Thank you. Dr. Greaves, I am pleasantly surprised, at the same time, very perplexed about your position on the need for a registry. Here I have a summary of observations and advice following a meeting of the 23rd of February 2021 of the Scientific Advisory Committee. And there are a number of recommendations made. On the fifth recommendation, it is stated that we have to review possibilities concerning the creation of a registry to pursue the use of high-risk devices. Looking at your position today, did you have another meeting at the Scientific Advisory Committee to reinforce your recommendations?
Thank you for that question. I think we have been in a variety of discussions over the past 3 years at the committee, reviewing the issues of whether or not there should be mandatory data provided
Dr.
on
Greaves,
a variety of drugs.
Dr. Greaves, hang on one second. I think, est-ce qu'il y a un problème avec les...
Is there a problem?
Ça recommence, oui.
It's starting all over again. It's starting.
You could start, just re-answer the question from the top because we lost translation there momentarily.
At the committee, we've had a number of discussions about devices, including breast implants. And we've heard testimony from patients at the committee about both cancer-related issues as well as more general issues and consumer advocacy. We recommended that we revisit the possibility of developing a registry to track the use, effectiveness, and safety of breast implants. The committee members who are well aware that these efforts to establish a registry had been ongoing for over 33 years, and we wanted that revisited. That is one of the reasons why the Best Brains Exchange was scheduled for March of this year. We also recommended that there be a retrospective
Juste une seconde,
case
excusez-moi,
study.
j'ai pas beaucoup de...
I'm sorry, one moment. I don't have a lot of time, but the recommendation dates back to February 2021. This is now May 2023. We received Mr. Boudreau from Health Canada, who seemed very concerned about the technical issues on how to create a registry. Don't you think that this is delayed, the need for a registry? That's the first question. Besides the February 2021 meeting, have you had other meetings amongst the 8 I have in front of me where you discussed the problem of breast implants?
We have discussed breast implants in the context of discussing medical devices in the Medical Device Action Plan numerous times. The details of that might not appear in the actual minutes because they are summaries. But we have recommended that the breast implant registry be revisited. And we've also recommended that breast implants be considered as a retrospective case study to investigate exactly how they were regulated in Canada and to identify the gaps that led to the current situation. And we've certainly recommended that we provide more information to consumers on a much wider array of evidence. And that is going to require, as I mentioned in my presentation, not just data from a registry, but also more specific qualitative and quantitative research on the issue that is in the public domain and that is publicly funded.
Could you send to the committee the minutes of all meetings of the advisory committee, 16th to 17th of May, October 2021, 23rd of February 2021, June 2021, February 2022, and November 2022. And you talked about March 2023, I imagine. Could you, well, we made a request. It's been more than a month. We haven't received anything now. I think it would be a good idea for us to read those reports. If you can do so, thank you.
On the website and publicly available.
Non, c'est pas sur le site web.
No, it's not on the website. I'm sorry. We did our duty. What is accessible is what you send or what you publish summaries. We want the entire minutes, the deliberations, minutes of the deliberations. Mr. Cohen Terva would be happy because you, on the 23rd of February, you made a recommendation, the creation of a research fund to improve scientific data on reactions to implants. Since February 2021, has this recommendation been implemented?
Not to my knowledge.
Santé Canada.
Health Canada thinks about creating a fund to cover funds related to damages. Has this file advanced since February 2021?
Not to my knowledge, although we did recommend that.
Bon. Est-ce que l'étude de cas rétro...
The retrospective case study that you mentioned as well, is it underway?
Not to my knowledge.
OK.
Very well. How much time do I have left, Mr. Chair? That's it. Thank you very much, Mr. Theriault.
For 6 minutes, please.
Thank you, Mr. Chair, and thank you to all the witnesses for being here. Can any of you give me or our committee a general idea how many Canadian women have been injured by breast implants?
Well, I tried to calculate that. So we could say that from the other experiments in other countries, it's calculated that about 25% of the patients with breast implants have issues that might be due to the breast implants.
Okay. Now, for those of us that aren't used to medical epidemiology and risk factors, is that considered a high risk for a what can sometimes be an elective surgery?
It's an extremely high risk.
Thank you. Dr. Cohen-Tvert, staying with you, if I had your words correct, you said there were some issues with implant trials. I imagine this was the clinical trials that were probably done by the manufacturers. Can you expand a little bit on that? What were the issues with the implant trials?
So the FDA recommended trials when the ban was lifted. However, these trials were not done and were not done properly. So we had an FDA meeting, I think 3 or 4 years ago, where I was also a witness. And there many patients actually came forward and said, well, I participated in these trials, but as soon as I developed complications, I was sent out of the trial because I had complications. So those are not proper trials.
Who was conducting those trials?
Mentor and Allergen.
Now, you've identified 3 major potential negative problems from breast implants: malignant disease, breast implant, ALCL. Number 2, autoimmune disorders, and number 3, so-called breast implant illness. Is there an implant on the market today that significantly avoids these 3 risks?
No, we did do a comparative study where we compared the modern implants with the implants that were placed 20 years ago, and we saw the same symptoms occurring in the patient. So there was no difference in implant quality. So although the manufacturers always state that their implants are better and better and better, right, we don't see that from a rheumatological or autoimmune field.
Okay, I'm going to ask an obvious question to a layperson. We have a device that causes an extremely high rate of serious problems, and I would take you to agree with me that malignant, the cancer, the autoimmune disorders, and the autoimmune nervous disorders are fairly serious, are they not? Conditions?
Well, causality is an issue here always. The malignant disease is clearly caused by, there is a specific mutation that occurs that is not seen in other forms of ALCL. The causality of breast implant illness and the breast implants is still debated. I recently put up research where we showed with the current Bradford Hill criteria, which is the criterion that we use to support causality, that breast implant illness is indeed caused by the breast implants. Bradford Hill, go back to the discussion with smoking. In the late 19th century, it was already clear that some patients who smoked did get lung cancer. However, it lasted until 1960, until it was proven, causality was proven that it was, and that was Dr. Bradford Hill who did that. So it is very difficult to fight against the manufacturers.
Sure. So if I understand you correctly, the BIA-LCL, at least one version, there is a causative aspect
Sure.
established. The Israeli studies said there's that, a large-scale study said that there's a 45% higher risk in women with breast implants to get an AI disorder over those that don't.
Yes.
And 25% of women would have 3 symptoms or more after 10 years after breast implants in terms of the autoimmune nerves. The question I would ask is, should we be allowing these to be implanted at all, given those health impacts, at least for people who don't have a medical, say, indication for one?
Yeah, so I'm not the one who decides that. But clearly, my statement is always, if we are continuing to give breast implants to healthy people, they should be well informed. And preferably, I would say, you are a guinea pig. And if you want to participate in this study, yes, you're allowed.
Awkward question, doctor. Do you have a daughter?
Yes.
Would you recommend that she get breast implants?
Never.
Dr. Morris, you indicated that there was a higher failure rate when we switched from gel to silicone. And I'm just wondering, was that because the envelope was different? Because one would think, I mean, it's the same material, saline or silicone. I understand they have different impacts, but why would the switch to saline, result in greater failures in the envelope?
I don't think I said that.
Okay.
So in the 90s, when the moratorium took place, silicone gel implants were taken off the market. So when patients had need of further surgery, we could only offer saline-filled implants. As a result of that, we all have a lot of experience of patients having their implants done, everything goes fine, and then they have a sudden deflation, 1 to 20 years later. And that was an issue because it's a sudden failure, so it's a complete failure. So it's a very obvious failure. The other thing, circling back to the complications issue, when you hear a number, like I do an operation, deep inferior epigastric artery perforator flap from the abdomen to reconstruct the breast, which is the alternative. We heard what are the alternatives to using an implant. So in a woman that's had a mastectomy, my option is an implant or tissue. So the implant's a 1-hour operation. Results are pretty good most of the time, or a 4 to 6 to 8 hour highly invasive tissue transfer operation. So I present that, and there's pros and cons of both, but patients, for their own self, they have the choice of not having a breast reconstruction after mastectomy, which some choose and is perfectly reasonable, or they'll decide to have an implant put in with a full discussion of the risks of that procedure, or they'll have the bigger operation. Now, the bigger operation that I do from the abdomen, in studies, has a 50% complication rate, which what surgeon is ever going to do 50% complication operation, right? That's crazy. But the thing is that in those studies, in that 50% are, little things like an abscess to a little stitch, or suture lines a little thick, or other things. So when you hear numbers like 25%, that's not 25% serious complication rate. We think that the ALCL is higher than we initially thought. Maybe 1 in 300 is the highest estimate I've heard, which is 0.3%, which is still very alarmingly high for that complication. But the other serious complications are hard to pin down. For example, the autoimmune, we have one of the world's experts here. He'll tell you that it comes in all kinds of forms. The BII, we had a conference, I was scientific director of our national meeting this year, and we had a full session on BII. Basically, does it exist? What are the diagnostic criteria? What's the test for it? There was no consensus at all. Does it exist was the first question that most people weren't sure that it actually exists. And there were certainly no diagnostic criteria, and there's no test to confirm it. So when you're talking about 25% complication rate, that's not 25% serious complication rate. There's never been a study in the literature that's ever implied that.
Thank you, Dr. Morris. Mr. Generou, please, for 5 minutes.
Thank you, Mr. Chair. Also want to follow my friend, good friend, Ms. Sidhu, in wishing everybody a happy Nurses Week. Quick story, Mr. Chair. Last week was National Physicians Appreciation Day. So I think many of you know that my wife is a physician, so I sent her a note saying Happy Physicians Appreciation Day. She sent me a note back saying thank you, and I hope that I can reciprocate that on National Politicians Appreciation Day, which I'm not sure if you've experienced that yet, Mr. Chair, but I have yet to experience that. So April Fool's Day. Fair, yeah. Anyway.
Here it comes.
Sounds like a great idea for a private member's bill.
Yeah, sure. Yeah. you lead with that, Mr. Chair, and we'll see how that goes. Sorry, I digress my time here. I guess getting back to the issue at hand, we had in front of us last week a Dr. Lennox, and he was suggesting that there was an informal registry already exists throughout I guess some of his colleagues, and he's through UBC. That was through, I guess, obviously it's not publicly funded. And then looking at some of the other countries here, Sweden, the United States, and Netherlands are all funded by either associations or something similar. I don't think the issue is so much on this committee. I've heard from all sides that want to ensure that we're doing everything we can to protect those who are experiencing these illnesses and going forward. To your tree analogy, Dr. Morris, I thought that was rather apt. So how do we get there, I guess, is the question facing this committee, at least in my opinion. And the private versus publicly funded, I heard Dr. Greaves kind of touch on the publicly funded piece. So if I might start with you, Dr. Greaves, and then kind of go around to the two in the room here, and just getting kind of the pros and cons for us to kind of assess this question.
Thank you. I think your witnesses last week talked about various pros and cons of models for registries. And as one of the prior witnesses today said, that's not my area of expertise. But I do think that aspects of public oversight are extremely important here in terms of making these registries mandatory and making sure that clinicians report quickly, especially about adverse events, but also making sure that recalls happen. I think the Australian registry is publicly funded, and this does not mean that the government runs it, of course. It means that the funding appears and is sent to managers of registries, such as universities in the case of Australia, and in other cases to professional associations. So I think the question of who runs it is different from who funds it. But I think to inspire some confidence in Canadians and the Canadian public, I think there needs to be the heft of the Government of Canada behind such a registry. And I think, fortunately, the one advantage of waiting 33 years to do this is that there's extremely good records and now investigations and reviews.
I only have about a minute left, so I just appreciate that.
I think we could rely on that.
I think that's a good assessment for sure. Maybe move to Dr. Cohen-Tervert for comment.
So I was involved in the Dutch registry. So the Netherlands, the medical specialists have a fund. So they funded the starting of the registry, and then patients were invited to pay for it, and that's mandatory if they they do not opt out. But also if they opt out, they still have to pay the $40 extra. And of course, for patients with cancer, it's reimbursed by health insurance, and for those patients who do cosmetic, not.
Great. And Dr. Morse, you had indicated you weren't an expert, but any thoughts on?
I think that the European model, there's a price per data point, so to speak, and the surgeons do the work of putting the data in. I think you need the legislative stick to ensure compliance, and there's going to be a cost to it. I think it has to be nationally run to ensure the trust of our patients that it's legitimate.
Is that CIHR then, in your opinion? Is it?
Could be. I mean, I'm not going to go there. I think you need your best people working on that. But I think it needs to be nationally run, and the implant manufacturers will pass on the cost. So if you tax them $25 per implant, goes into the fund, pays for the thing. Either way, government is going to pay for it because the half of the implants that are used for reconstructive purposes will come out of the public purse anyways. So.
Thank you, Dr. Morse. Next, Dr. Hanley, please, for 5 minutes.
Thank you very much. Thanks to everyone for appearing today. I wanted, Dr. Tervert, in the middle of your presentation, I think you were going to be talking about requirements for registries, and you had to shorten that. I wondered if I could give you a minute or so to elaborate on that.
One thing which is important is, of course, the privacy. In the Netherlands, it is arranged that the patient data are anonymous. With up-to-date encryption, that's a very good ID, and that gives the privacy a good perspective. The other thing which is important is which data should be used. There is international consensus on the data. So in Australia and the Netherlands, the same data are more or less registered. But in addition, there should be a committee that should look also at the prompts, so the patient-reported outcome measurement, which is very important, I think.
Okay, thank you. Dr. Morris and Tervert, you both mentioned that, the basic categories of reasons for implants. I'm wondering, Dr. Morris, whether the reason for an implant, I guess almost like the premorbid condition, does that play a role in, are there differences in complications per category of reason for implant? Maybe either of you could comment on that. Or is this another area where we just don't have enough data?
I've been going to meetings, hearing papers on breast implants and breast reconstruction for 30 years, and there's never been a consensus on anything. In fact, different surgeons will argue for different implant types, and again, we just don't have enough data to make sweeping cases for that. I mean, there's certain body types that seem to lend themselves to certain localized complications, but these big things, like these, things that we don't really know about, it seems to be random.
Yeah, so there is some recent updates. So there's a paper which is in press now from the first registry. So this is a combined paper from the Australian, Dutch, Swedish registry in combination with the small registry from the United States, because in the United States only 3% of the registry is done. That paper clearly shows that complications are much higher in the reconstructive patients than in the cosmetic patients, with about 15% reoperation within 2 years for the reconstructive versus only 3% in the cosmetic. Importantly, however, we always say 30% is reconstructive, 70% is cosmetic. In these registries, it was different. It was only 8% was reconstructive and 92% was actually cosmetic. So we may underestimate the cosmetic amount of breast implants a lot. And only these registries now show that it's probably much higher cosmetic and not reconstructive.
Dr. Morris, in your practice, do you see differences in outcomes?
That's the problem with the data is every surgeon has their own skewed patient experience, and mine has been mostly reconstructive over time. So, that's how useful it is hearing an isolated paper from an isolated surgeon at an isolated meeting. It's it's helpful, it's entertaining, but it's not useful.
It's always refreshing to have someone understand their own limitations as an individual. Exactly. Dr. Graves, you're a social science researcher and expert in women's health. The fact that we don't have a breast implant registry, do you see that as a gender equity issue, or is it more just that we have a general regulatory gap, or maybe a lack of diligence or attention to monitoring medical device complications overall?
Both of those things are true. It is a gender equity issue. And I think some of the, 30 years ago, some of the regulations surrounding breast implants clearly illustrate that. And they're on the timeline in the document I gave you, that we were late to including breast implants, among other devices and regulations in Canada. But I think the overarching issue about medical devices in general is also true, that we need vast improvements in those systems, not at least including sex and gender related issues in the data and making more attempts to measure those things in submissions by industry and other areas. I think the business of utilizing breast implants needs to be addressed in research, qualitative as well as quantitative, what the reasons and motivations are. And I think we have a responsibility via Health Canada and other efforts in Canada to spread knowledge and raise questions about the usage of implants and whether or not there are alternatives for women as they choose either cosmetic or reconstruction.
Thank you, Dr. Greaves. Monsieur Thériault, pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. I'll be quick. Dr. Cohen-Tevot, Mr. Boudreau of Health Canada came here and said that there wasn't enough scientific data to recognize, as the FDA did, the breast implant illness. In the report for immunological clinicians, a report I will ask you to table, it was entitled
Its existence.
Breast Implant Illness, Scientific Evidence of Its Existence. That was the title of the report. So what I was saying is that when we don't have scientific data, but we must ensure the safety of women, considering a high-risk device, we use the precautionary principle. What do you think about that?
Oh, I totally agree. So one of the issues in breast implant illness is that it's clear that patients do better after explantation. So most symptoms disappear. And we recently published just a few months ago that re-challenge, so meaning that when they get another implant, caused a failure in 70% of the cases. So and that's a very hard argument for scientific evidence. So challenge, de-challenge, and re-challenge. But also the other. So I think Health Canada is wrong. There is a clear issue with breast implant illness. And in the field of autoimmunity, it's not debated. So it's clear that there is a disease that, and more we are now going into the pathophysiology of this disease. And so on the latest conference in Athens, there were posters and discussions that in animal models, if you inject the serum of patients into animals, you can develop a similar disease as what has been shown in breast implant illness. So it's a matter of time, I think, to convince the world that it is a specific disease that can be treated with explantation.
Thank you, Dr. Cohen-Tevert. Mr. Davies, please, for 2.5 minutes.
Thank you. Cohen-Tevert, just picking up my colleague's question, I mean, I think a physician's first admonition is to do no harm. My question would be, I'm hearing, unless I'm hearing wrong, I'm hearing a little bit of difference of opinion between Dr. Morris and yourself on how solidly these connections might have been made, but do we know enough? Is there enough in the literature right now to at least give your average doctor or breast implant surgeon enough information to suggest that there is a significant risk of illness if they implant these devices in women or other people?
Yes, it's clear. So in the Netherlands, already in 2013, the health authorities warned all plastic surgeons for breast implant illness, especially those patients who are having a history of allergy. Another group of ladies that's important is those who have already an autoimmune disease or those who have a family which is full of autoimmune diseases. So those are clearly described risk factors. Mm-hmm. Of course, we need more research to develop better markers for who is really prone to develop this disease. But yes,
so I'm curious.
There should be warnings.
So I'm curious, what is the state of a warning in Canada today? Like, what's the guideline? What would your average Canadian plastic surgeon be telling a woman or other person who may be coming for breast implants? What are they going through these 3 diseases? Do they have to? What are they telling them?
That's a question for Dr. Morris.
Dr. Morris?
So, in an informed consent situation regarding an implant, a breast implant, a surgeon would generally discuss capsular contracture, number one, malposition or mechanical issues with not getting a great result, infection, hematoma, collection of blood around the implant, scar-related issues, extrusion, which historic, I don't think that happens currently. And then the rare chance of other things, such as anaplastic large cell lymphoma or autoimmune things or other things that we don't know yet. Because we don't know everything in surgery. And with any of our surgeries, particularly one in which you put something in the body that is meant to stay there permanently. So we don't know everything about these things. Breast implant illness, I've been doing breast implant surgery for 30 years. We only heard about it really in the last 5 years. But before that, I had lots of breast implant patients who I followed annually and had no problems at all. So what's the subset? Who's at risk? If somebody had a history of autoimmune, certainly that would ring some alarm bells. But we really don't know it. And it's not that we're concealing, because we're not the implant manufacturers. Right. We have nothing to gain. We're responding to patients who come to us wanting certain procedures.
Well, don't plastic surgeons have something to gain?
Thank you, Mr. Davies. It's your past time. Mr. Abultayev, please, for 5 minutes.
Thank you, and thanks to the witnesses this morning. I've got a few short questions for a few short answers, if that's okay. Can you forgive me because I do have other questions to follow. The first question to all of you, is registry a must? Yes, no?
Yes.
Yes.
And
yes.
Okay. Now, should registry cover implants done outside Canada?
Yes.
Yes.
We should have an international registry, yes.
There are many stakeholders to registry, some with, some against. Who do you think that would not prefer to have registry or would not be siding with having a registry in Canada?
I think the main obstacle to creating a registry has always been funding. And how do you organize it and how do you make it truly national? And I think those are things that we can overcome.
I think it's the surgeons who should do it, and especially surgeons working in private clinics who may be a little more difficult. So that's why in the Netherlands they say, okay, you lose your license if you don't do the registry.
I would agree. I think those surgeries taking place in private clinics are probably the hardest ones to follow, and there may be the most resistance there.
There was mentioning that it's been 33 years since first discussion on having a registry, and so far nothing has been done. In the meantime, by the time we agree on registry and all the complications of finding that proper legislation to take place, can government regulation or ministry regulations be able to replace some of the conditions that registry can provide?
I think it's a governmental issue to have licenses for clinics, for private clinics. And we have to realize that there is already a long time registry for hip and knee implants. And in many countries there's cancer registries. So why not for this? I don't know.
So compliance is always a problem with the registry. And without 90% plus compliance, the registry has little value. It could be criticized or it could be doubted. In order to have the trust of the Canadian population for the safety of breast implants, I think it's inherently the government's responsibility to provide that. I think that you have a big stick in terms of legislation to ensure compliance.
Dr. Graves?
Yeah, I think, as I mentioned already, the improvement of mandatory reporting of adverse events for all medical devices needs to happen quickly. And in particular, it needs to be extended past hospitals and past manufacturers to individual practitioners and private clinics and private settings, including long-term care homes and private clinics that have been promised but have not happened yet. The other aspect to this is consumers. And up until recently, the way to file an adverse event report for a consumer was very hard to understand and was quite obscure. And I think that's been improved, but there's a long way to go to make that a much more publicly and well understood system, so we could get more reporting that way as well.
Thank you. A question, and you feel free not to answer. Is the industry in favor of registry, yes or no? Dr. Grave.
I can't speak for the industry, obviously. I have seen examples where the industry has been supportive, but I don't know the answer to that.
Dr. Gervais, I hope I... Okay. In terms of Asia, which is a term that you've used, can you expand on the impact that different properties of breast implant in relation to an increased susceptibility to develop in Asia?
Okay, so Asia is when you implant anything in a human body, there is an immune reaction to that. So it's not specific only for breast implants. So we see this more often in breast implants than in other implants, but it's still not specific. And so it is also the same inflammation causes actually the contractures. And also the same inflammation finally causes ALCL. So it's a ALCL is in fact a mistake of the immune system by attacking and dividing cells, then go wrong, and then it's a lymphoma. So it is all one same similar mechanism that's occurring in these patients.
So if there is...
Thank you. That's your time. Yeah, that's your time.
Thank you.
Mr. Vancouver, then, please, for 5 minutes.
Thank you very much, Mr. Chair, and thank you to our witnesses. This has been extremely interesting. And I'd like to join my colleagues in first acknowledging that this is, of course, National Nurses Week. So thank you for bringing that up. But I'd also like to say to Dr. Tavert, since last week was Dutch Heritage Day in Canada and Dutch Liberation Day in Holland, as a Canadian of Dutch descent, I feel an obligation to say Happy Dutch Heritage Day as well to you. And I think now that we've had a few meetings on this issue, it's less about the if and now about the how. So we're kind of exploring, gotten over whether or not this would be a necessary implementation or consideration, and now we're starting to discuss the nuts and the bolts and the next steps. And I think it's important to acknowledge that Canada has some fairly unique challenges around health data. Federalism gets in our way of a lot of great ideas sometimes, and we have in Canada a patchwork of data privacy laws across the country, and we're quite behind, a decade behind, if not more, in terms of being able to make that data interoperable and be able to communicate. Did have a recent meeting with some AI specialists to discuss the fact that there might be a faster solution to that than waiting 10 years for all of the systems to be changed. But worth acknowledging that our government recognized the challenges with respect to data back in February and made data a pillar of our $198.6 billion investment over the next decade in our healthcare system, with standardized health data and digital tools. But at the same time, the collection and the use and the disclosure of all of that data is still up to various provinces and territorial jurisdictions that don't necessarily talk to each other in the right language or in the same language. Moreover, those regulations are governed by provinces and territories and that health privacy legislation. So these are unique challenges to Canada. Canada's often, it's often said that Canada's 13 countries that pretends and tries to be one. But these are the challenges that face us as legislators, and the fact that these privacy and data laws vary widely across the country might pose unique challenges, but it's something that we need to tackle. But for example, some provinces might also have to initiate legislation in order to in order to be in compliance, because there is certainly issues with respect to privacy. So it'll require more than one piece of legislation in order to get a registry in every province and territory. Do you have any suggestions or solutions for overcoming some of these jurisdictional issues in the context of a registry in Canada? That's a question for anybody. Fairly broad bet, broad strokes. For example, have you ever been to a provincial committee meeting like this to discuss these health concerns?
Well, the registration in Alberta is top, so it's one of the best in the world. So, but I'm not sure that the other provinces can do the same. But,
no, I think. Sorry.
I can say that Australia may have addressed some of these questions with interstate issues, and that might be worth investigating for the committee. And secondly, one of the private members' bills that I mentioned in my timeline took place in Ontario. So at least at that point in time, there was some interest in one province around doing this, in addition to what we've already seen happen. So I do think it's an FPT issue, but that should not stop us.
No, I thought this was a place that all those important decisions happen.
Yeah, well, we try. The other issue that came up was with respect to cost. Can you point to any jurisdictions that, overcome this cost? Is it usually a government obligation to pay for these registrations or this registry overall, or is it something that industry or other costs can accommodate?
I think the best approach going forward is at the federal level, creating it as a Government of Canada initiative through whichever agency, and then making industry pay for it.
I'm not sure that it's making industry. It's making patients. I mean, it's your choice to do the cosmetic surgery. And if you have a reconstruction, it will be paid by the insurance.
And in Alberta, Dr. Tavert, you mentioned it's world-class. How is it paid for in Alberta?
It's not clear. So I don't know.
Thank you both.
Thank you.
Over to Dr. Ellis, please, for 5 minutes.
Well, thank you very much, Chair, and thanks to the witnesses for being here. I guess we've talked about this issue for a very, very long time, and I guess part of the question I have is why wouldn't we do this? I mean, here we are, we've been doing this for decades now, putting implants in people, which we obviously know are foreign objects. And why would we not want to track that and have more science? From my perspective, it seems really quite simple, and I guess maybe we're just arguing about perfection being the enemy of progress. And I guess I'd love to hear from the witnesses of, do you have any objections to doing this? What would be the downside of doing it? Maybe we start with you, Dr. Morris.
Dr. Ellis, fellow Nova Scotian. So there's a lot of obstacles, and that's why it hasn't been done. It's tough. It's going to be a tough uphill slog to get everybody on board. The Best Brains session was excellent, but there were perspectives on it that I hadn't even thought of before. And I think we just have to get everybody to the table who has something to offer, improve the registries that are out there internationally, figure out the funding model, and execute. The surgeons will come on board when it's, as in the Netherlands, mandatory. There's compliance, immediate compliance with that. And I think everyone gets it that we need the data, and the only way to get the data is roll up your sleeves and do it. And then have constant surveillance on it. But inertia is the hardest thing to overcome.
I would say, I would agree with you that perfection is in the way here of launching something. And I don't think it should be. I prefer to think about this from the point of view of the women and other patients who are receiving these. And to me, I think we have a huge obligation to them that we have not fulfilled over the last 30 years. And that needs to be done, even with an imperfect registry.
I think the big issue is, compared to the Netherlands, the surgeons that place the breast implants here are less well organized. So in the Netherlands, it's easy to say, okay, you lose your license as a plastic surgeon if you don't agree. But here that will be a little more difficult, I think.
Well, and thank you all for the answers. And through you, Chair, we've heard about an implant registry for orthopedic devices. Obviously, that has been in existence for some time. And I guess in my mind, I can't see a reason why not to, I'll use the term piggyback onto such a registry to say that it already exists. I realize they're different. But that being said, the basic information that's collected, perhaps you don't know anything about it, and that's okay. But does that seem a reasonable starting point, considering it already exists at a federal level? If you have any comments on that, let's go in the same order, if we could, please.
And that's a great model because they picked up some things that changed patient care and ensured greater safety in the OR. So I applaud them for doing that, and I think that would be a great model in Canada to at least study.
Yes, I would agree. That and other international examples of breast implant registries are also informative here. I think the issue of healthcare utilization should concern Health Canada and the rest of us, especially in current crises with the healthcare system. So I do think there's lots of really good motivations for tracking these matters. In addition to trying to reduce the usage of breast implants in general by having much better education for patients.
Would be medical tourism. So at least from Alberta experience, many patients did have breast implants in Mexico or elsewhere in the world.
A great point, thank you. And perhaps one further question, Chair. Dr. Morris, you talked a lot about the alternatives with respect to reconstruction. Obviously, the newer surgeries, the tram flaps, et cetera, create significant issues in terms of time under anesthesia, recovery, et cetera. If we understand that the newer techniques take longer, breast implants much quicker to be done, and perhaps that's the reason. But that being said, we don't see breast implant surgery going away anytime soon. Then we obviously need to sort out some of these issues like HESA and BII and ALCL. Does that make sense that we need to study this more closely?
Absolutely, I agree completely.
Thank you, Dr. Morris. Dr. Ellis. Dr. Pawlowski is next, please, for 5 minutes.
Yeah, I got a whole bunch of questions. Some of these haven't come up earlier. Textured implants, my understanding, have a much higher incidence of anaplastic large cell lymphoma. So I assume you're not putting them in anymore. Are you actively taking them out when somebody has an implant?
I didn't put any in, so fortunately I don't have to take any out.
Are other surgeons?
It's certainly a discussion point. So in the surgeons that are able to track their patients and have tracked them, they bring them to the office and have the discussion and explain the situation. But that leaves about 80% of patients that aren't identified.
Okay, so that was exactly where I wanted to go. So right now, when the surgeon, or in the past, when they put in those implants, there was no onus upon them to notify the manufacturer that this individual received one of their implants, right?
So there's multiple layers to the answer. So in Canada, since the 1990 moratorium, we've been delivering our data back to the implant manufacturers, but that was a black hole. We didn't get any data back. So the implant manufacturers should have some records of that in Canada, but we don't ever receive that.
Some records, so that means that when, and I know you didn't put those implants in, but say a surgeon that was putting those implants in, they were expected to, and were they sending the name of the individual and their address to the manufacturer of the implant?
I believe so. We've been doing that with our implants, with a different company. But I've never received anything back from the company saying blah, blah, blah. And I don't know how long they keep the records, and I don't know what they do with the data. But this committee could find out.
So do you know then, have the manufacturers then, given that they may have a list of people that had that higher risk implant, have they been actively trying to locate and notify those who've had those implants?
I'm not sure, but the surgeons I know that had patients like that were going through their records to identify those patients and offer a follow-up.
So in the absence of the industry taking this on, it's been left to the individual surgeon, if they, and hopefully most of them had that sense of responsibility, that they'd have to go all through their records, find out who had these implants, and then identify. So this is kind of, given the fact that we haven't had a registry, this has been the kind of de facto system people have been using.
So I can't speak exactly to the details, but I think that's the case.
Okay. And then I worked in developing countries where I did a fair bit of surgery. I worked a long time in the emergency room. We as doctors, we leave a lot of sutures in people, but certainly also coils, stents, replacements. Is there no requirement on the makers of these things that we have historically left in people to do trials beforehand to ensure the safety of what we're putting in people? As they do, for example, in pharmaceuticals, where you have to have like phase 1, phase 2, phase 3 trials. Is there no equivalent to that for things, implants?
Unfortunately not.
Pardon me?
Unfortunately not, no.
In no jurisdiction in the world is there that
No,
requirement?
it's if you have a stent already on the if a stent is already registered, a new stent with a different should only be show that it's equivalent to the old stent, so that there's no large randomized controlled trials before they are entered into the market.
In your opinion, in both your opinions, ought there be such a requirement before putting such a product on the market? They go through
I used to be a member of the committee for the pharmaceutical in the Netherlands, and my opinion was always they should be the medical device should be at the same level as the medications, but it's nowhere.
Dr. Morris?
It makes a lot of sense, and I'm not exactly sure what, breast implant manufacturer A does before they bring something to market. I don't actually know what they do. I'm sure they have some beta testers, but I'm not sure how rigorous it is.
But the history of this comes from the fact that we were so happy with medical devices, that such an urgent need for these things, for new technology in patients, that especially the FDA actually decided not to have all these difficult questions before it can be entered in the market.
Now, did I heard you right that,
thank you.
in the
Thank you, Dr.
U.S. only
Pawlowski.
3% of women who have implants?
Thank you, Dr. Pawlowski.
Cut off.
Monsieur Thériault, 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Dr. Morris, a while ago you talked about obstacles. Obstacles linked to the introduction of a registry. On the one hand, you say that we shouldn't count a lot on manufacturers. That's in your text. At the same time, while responding to my colleague Davies a while ago, you indicated that surgeons have nothing to lose, but at the same time, well, I'm not trying to fault you, I'm just trying to understand. You said that if it's not mandatory, surgeons will not do it. Why wouldn't they do it?
Cette résistance.
I won't try en français because it's an effort. It's extra work. The surgeons are very reluctant to participate in studies because it takes an extra effort to collect the data and submit the data. That's the obstacle number one in almost all the clinical studies that I've been around, in my experience. So to get good data, you need compliance, and compliance can't be voluntary. That's my point, is that there has to be mandatory compliance amongst the surgeons to collect the data.
Est-ce que cette résistance-là...
This reluctance, will it not cause us to doubt informed consent? Shouldn't we require a format where everything is listed? Because if it's complicated, it's also complicated to explain all the risks associated with implants.
Oui.
Ça a le mérite d'être clair.
It would be nice to be clearer. Do I still have time? Great. Over the past 10 years, you talked a while ago about the fact that we had little data, little information. Over the past 10 years, what's the trend by surgeons towards organizing colloquiums to inform and be informed, to have continuous training on implants, because they have to inform their patients? Because when you look at the pharmacological model, it's usually pharma companies that provide training to doctors. Unfortunately, is there an appetite amongst doctors to inform themselves so that they themselves in turn can properly inform patients?
Maybe I can answer that question. So I've been invited by the surgeons to talk about mesh implants. I've been invited by orthopedic surgeons to talk about orthopedic implants. I've never been invited by plastic surgeons to give a talk on breast implants.
Thank very briefly, please.
Yeah, we go to meetings every year and listen to presentations about safety issues, about which implant's better, which has a lower complication rate. It's absolutely part of our DNA to always try to do the right operation and use the right materials for it. It's a constant discussion in our specialty. I might go to 4 or 5 different scientific meetings a year looking for improved techniques. So it's part of what we do all the time.
Thank you, Doctor. Mr. Davies, please, for 2.5 minutes.
I'm curious if any of you know what the general ballpark global economic value of cosmetic breast implants are, and what that figure might be in Canada.
I have a slide on that, but I don't know it by heart. So I have to look it up, but it's a lot.
In preparing for this appearance, I heard one estimate of 2 million breast implants per year in the world.
Okay. And do you know in Canada? No?
Sorry.
Dr. Graves, do you happen to know?
No, I don't.
Okay. I'm trying to figure out who's ultimately responsible for the safety of these devices. Is it the surgeon who puts them in, or is it Health Canada who is charged with regulating these and, I guess, protecting the public from, presumably, from having unsafe devices implanted in them? Or is it the manufacturer, or is it all three?
Well, if you compare it with medications, we doctors are responsible for the medication that we prescribe. Although, of course, the manufacturer has to give the medication as it is. So it should be, if we prescribe, for instance, penicillin, it should be penicillin. It shouldn't be something else. So there's the regulatory factor. But as a doctor, we are responsible for the side effects of penicillin. If we didn't explain that to a patient, that there could be an allergic reaction, and the allergic reaction could be very severe even.
Do you see there any potential liability of Health Canada by not having a breast implant registry, Dr. Graves?
Yes, I do, because Health Canada is responsible for the management of drugs and devices, among many other things. And that means they're responsible for the quality of the submission data that they request from industry, the review of it, the collection of adverse events, and the post-market vigilance, and then reviewing and perhaps amending regulations surrounding devices and drugs as a result of that circle of evidence that is constantly being reviewed. So Health Canada is responsible for that regulation, and it also is liable when things go wrong. And that's another aspect to this, not just on breast implants by any means, on all drugs and devices that needs to be reviewed. And we certainly have history of examples of that, such as thalidomide drugs, for example, that were used in Canada in the 50s and early 60s that were not used in the USA because of different regulatory decisions. So, yes, Health Canada is responsible for this.
Thank you, Dr. Greaves. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. It's an interesting discussion. I guess I still can't wrap my mind around the fact that, surgeons want it, patients probably want it, although they're not really sure that they need it. And I guess I can't understand why we don't just move on. I realize it's expensive, et cetera, but it only makes common sense. And I guess the other thing I would point to is, in my mind, the manufacturers do bear some complicity in this and some reasonable amount of need to be part of the system, in the sense that, if you own a car and something happens to it, you get a notice that there's a recall, and your manufacturer sends you a notice and says, hey, you better come and get this fixed. I realize that there's a middle person in here, namely a surgeon, and that may make it more difficult. But that being said, Dr. Morse, you talked a bit about the textured implants. Maybe you could just tell us a bit about that process. Obviously not textured in your sense, so it'll keep you away from the manufacturers. But if you were to choose a particular implant for a patient, tell us a bit about how that's tracked or what's happening at the current time, just so we can understand that.
So, complicated question, but if you grow up in a Ford family, you tend to drive a Ford. Same kind of analogy. I'm no plug for Ford, but the surgeon that trains you tend to adopt a lot of the things you saw worked. And so I worked with surgeons that like smooth, round, company A implants, and that's what I used. And I didn't see anything at all those meetings I attended that would dissuade me from that. And it was a good choice because those ones hadn't caused really any problems that we know of. So the textured implants were introduced by the company, and it doesn't sound like they went through a rigorous FDA-type drug evaluation, but they were introduced because that interface between the texture and the capsule of the body, the response, was supposed to lessen that capsular contracture. So it was all about trying to innovate to reduce a complication, and they created a different complication, like introducing a different animal in Australia to get rid of a problem. You create another problem. So the whole choice of implants has historically been surgeon biased. And to answer the earlier question about is there bias in literature, there's been well-documented studies that there's bias in every aspect of the scientific literature, whether it's recognized or not. So industry is a classic example of producing biased research findings. And so when you have a patient demand for the service and you have limited number of options, you pick which one you think is good and you check with your colleagues, you go to meetings, and you try to be aware of your patient's needs.
So through you, Chair, when you chose that implant A, let's call it, for patient X, there must be a documentation process. Obviously, in the medical record, you document the serial number, the manufacturer, et cetera. And what happens then to that information?
So I dictate it into the operative record. I provide the patient with a copy of the implant details, and we send a copy to the implant manufacturer. And I always thought it was a bit odd, thinking that it should go maybe someplace a little bit other than a company that just sold us the implant. Particularly if there were failures, we sent them back to the company. But of course, that's not very transparent because, we should have access to that data.
So through you, Chair, realistically, Dr. Morris, that company A knows that patient X had that particular implant procedure done by yourself. So theoretically, then, they could, if there were problems with their implant, they could let the patient know independent of you?
I'm not sure that they would have all the demographic information, so possibly.
And through you, Chair, though, on the other hand, they could notify your office and say, hey, this patient, number 10452, had this particular implant A implanted. We know there's problems with it. So that's another avenue that this could actually happen as well.
Yes, absolutely.
So, all in all, there are a registry of some sort that exists. It's just not accessible for those who might want the scientific data associated with it to perhaps better understand illnesses like BII from Dr. Trabert. Is that fair, Dr. Trabert?
No. So I see it the other way. Patients come to me with complaints. Then I ask, what kind of brand do you have? What kind of texture? Is it textured or is it smooth? Most patients don't know. And then I ask them, well, can you contact your plastic surgeon? And then even several patients come the next time and say, well, they couldn't find it. There was no registry. It's not known. So it is not as perfect as it should be.
Not at all perfect. In fact, with the limitations of the medical records, in fact, the medical records will only stay in the office for 7 years. Surgeon may retire, move, die, and the records are lost.
Thank you.
Last round of questions will come from Mr. Johari, and after that, there's going to be a request for some documents as well. So go ahead, Mr. Johari.
Thank you, Mr. Chair, and I'll be splitting my time with MP Thériault. Dr. Morris, I'm going to point my questions to you. You talked about medical tourism, and what we've seen traveling to other destination to combine getting a breast augmentation as well as having a recreational getaway is becoming a lot more prevalent. You talked about Mexico. We know about Turkey is becoming a hub for doing a lot of plastic surgery, as well as Colombia. Now, what procedures do we need to make sure that it's in place for those patients who are seeking to get those augmentations or those procedures done, to ensure that we can get access to those records? Because Do we have a procedure in place to get the type of implant that's been put in there? Are they approved by Canada? And when the procedure was done, who was the doctor, and then tracing it? Those are some of the challenges, and I think you touched on it. You got about a minute before I yield the floor to my colleague to respond to that, because I think that's an area that we really need to address.
It's a very interesting and important question, which I can't answer, basically, because these patients don't even come to see the plastic surgeon before they leave. They make contact with a surgeon in a different country, probably because somebody in their family has already been there. So I think that is education. I mean, I think that we have to get the message out that there's potential consequences, and we see the complications of those procedures. So we'll pick up certain complications related to the medical tourism.
Yeah, thank you. Dr. Trevor, have you seen anything like that in in Holland, and how did you manage it?
I've seen it in Canada a lot. I mean, medical tourism is here a big issue, and yeah.
So how should we
we
manage
see the
it?
complications? But yeah.
Okay, so
and generally, your question: are all these implants on the market here? No, they're not.
Okay, I guess thank you. That's my 2.5 minutes. I yield the floor to MP
Monsieur Thériault, 2 minutes et demi.
Mr. Thériault, 2.5 minutes. Microphone, please. My question goes to Dr. Morris. Before we request for documents, did you invite Dr. Cohen? Are you going to invite him during the next meeting to provide more information to your surgeons? Absolutely, yes.
Okay.
Très bien. Very well. Mr. Chair, a while ago, maybe I was too fast, and I would like Dr. Graves to take note of these documents. At the end of the document I referred to, the Advisory Committee Summary of Recommendations virtual meeting of the 23rd of February 2021, it says that the minutes of deliberations are available upon request. Please submit your request to X. There's an email address provided. We did that. That was more than a month ago. Nothing has been received to date. So please send to the committee the minutes of the deliberations of all the meetings that the advisory committee has held, please. Then, Dr. Cohen-Tevert, you talked about an article that was recently published. I would like you, for the benefit of our colleagues, to table it so that we can read that article as well. That's all.
Okay. And Dr. Pawlowski, I think, was looking for some documents as well, and then we can wrap it up.
Yeah, so out of this, we're going to produce a report that goes to Parliament, which hopefully will be basis of further government action. We can take into account both testimony but also what's been submitted. I think it was Dr. Tevert mentioned that only 3% of women in the United States who receive implants are part of the registry. If you have any documentation about those numbers and why so few are on the registry, if you could please submit it so it could become part of our report. Thanks.
And just on that, for all of our witnesses, you absolutely have the right to provide any further materials in written form that you think might be helpful to us. So, in addition to what's been requested, if you think there's anything else we should have, we'd like to have it. Okay, colleagues, we have about 5 minutes remaining. We can. If there's anybody else that wants to pose a question in the last few minutes, I don't think we don't have time for a full round. If not, we can. I have 2 other items I want to raise before we wrap. Mr. Thériault?
Mr. Thériault, my question had to do with the independence of continuous training for surgeons versus the industry. At the pharmaceutical level, are there many colloquiums organized related to the industry, Or are your surgeons more autonomous? Are there scientific and independent colloquiums that are organized in the continuous training that is provided?
Completely independent. Our education doesn't come from industry, it comes from other surgeons. So it's frowned upon to have industry supporting educational events. That was not that uncommon in the past. So maybe 10 years ago, 15 years ago, it would be common for industry to support educational events. But now there's a very strict line separating education from industry.
Okay, I open this door. We have, let's go with one question each, Dr. Pawlowski, Dr. Kitchen, and Mr. Davies. Dr. Pawlowski.
I think it was Dr. Tervert that mentioned breast implant illness. Isn't it? Did you say it was kind of an autonomic neuropathy? Is that what it is, and related to inflammation? Or sorry, if you could clarify that.
So it's called a dysautonomia. So it's something which is in the autonomous nervous system that goes wrong. So for instance, the typical issue that your eyes are very dry and your mouth is very dry. That's something of the autonomous nervous system, and that's something which can be transferred into animal models.
Dr. Kitchen.
Thank you, Mr. Chair, and thank you all for your presentations. Greatly appreciated. My question actually is really more just the chair indicated that you could submit further information to the committee, and I would be interested to know if you can do so or would be prepared to do so, is providing without going into a great deal of detail, but what you think should be collected in that registry, in particular signs and symptoms. And those aspects of things that you think should be specifically reported such that that data is included. And if you could provide that to the clerk, that would be greatly appreciated.
Thank you, Dr. Kitchen. And to wrap up, Mr. Davies.
I just wanted to give Dr. Graves a chance of last word. Sometimes when you're the witness online, you don't quite get the same presence. I just wanted to give you the last minute or so to leave us with your thoughts.
Thank you. I appreciate that. I have mentioned a couple of times that I think we have omitted paying any attention to the motivations for requesting implants among patients, whether cosmetic or reconstruction. And I think this is a big omission that could go some way to improving the general health of women in Canada and those requiring or requesting implants if we paid some attention to those motivations and then did some education around them. It's not clear, but some of those motivations are around body image and predominant body image pressures that girls and women face that lead to cosmetic requests. And with respect to reconstruction, we do know from some cancer survivors that they face the question of whether or not they should reconstruct or not. And the pros and cons of doing that often are related to body image issues as well. So there's an entire area here that I haven't heard a lot about in research or even discussed today that could go a long way to reduce the use of implants. You heard one of the other witnesses today that he would not recommend this to his daughter, and I certainly wouldn't recommend this device to anyone I know. And the best breast implant is probably one that's avoided. So I do think we have an obligation to begin to think about that as well and collect some data on motivations. And then among those in a registry who have had implants, to collect data on whether or not their mental and physical symptoms that result are improved or not improved. So those would be some of my final comments. Thank you.
Thank you, Dr. Greaves. I'd like to thank our witnesses for being with us here today. The depth of your experience and expertise is very clear, and the information that you have provided will undoubtedly be valuable to us as we start to put together some recommendations from here forward. So thank you for taking the time. Thank you for being so patient and so thorough in your answers. 2 items before we adjourn, colleagues. Later today, we will receive documents from witnesses that appeared for the study of the Patented Medicine Pricing Review Board. These will need to be translated, so there will be a delay, but we will ask the Translation Bureau to prioritize this request so that we have it back as soon as possible. And on another note, it is with some regret that I have to inform you that our illustrious analyst, Sarah Dodsworth, is going to be leaving us. She's not going far, but she will no longer be attending committee meetings and providing the excellent service that we have enjoyed during her tenure. So I'm sure you join me in wishing her all the best in her new responsibilities within the Library of Parliament. Would you like to give a speech, Sarah? Is it the will of the committee to adjourn the meeting? We're adjourned.